Stroke is a leading cause of disability worldwide, often leaving survivors with impaired upper extremity function. Rehabilitation plays a pivotal role in helping patients regain independence and improve their quality of life. In recent years, new therapies using electrical and magnetic stimulation have emerged, aiming to enhance recovery beyond what conventional rehabilitation offers. But which of these interventions is most effective? Today, we'll explore the latest evidence from a comprehensive systematic review and network meta-analysis, comparing various stimulation therapies for upper limb recovery after stroke. After a stroke, up to half of survivors struggle with daily activities due to upper limb weakness or paralysis. This loss of function can severely impact independence, making tasks like eating, dressing, and personal care challenging. Improving arm and hand function is therefore a top priority in stroke rehabilitation. Various neurorehabilitation techniques have been developed to target these deficits, aiming to promote neuroplasticity and restore movement. Understanding which interventions work best is crucial for optimizing patient outcomes. Several stimulation therapies are now used in stroke rehab. These include neuromuscular electrical stimulation, NMES, functional electrical stimulation, FES, transcranial magnetic stimulation, TMS, and repetitive peripheral magnetic stimulation, RPMS. Each method works differently. NMES and FES use electrical currents to activate muscles, while TMS and RPMS use magnetic fields to stimulate nerves and brain regions. Some therapies are even combined for potentially greater effect. But how do these compare to standard rehabilitation? Researchers conducted a systematic review and network meta-analysis, searching 5 major databases for randomized controlled trials up to July 2022. They included studies comparing any of the stimulation therapies, alone or in combination, against each other or conventional rehab. The main outcomes assessed were upper extremity function, activities of daily living (ADL), and spasticity. In total, 34 studies with nearly 1,500 patients were analyzed for upper limb function, making this one of the most comprehensive reviews to date. Evaluate the effectiveness of each intervention. Researchers looked at 3 main outcomes. First, upper extremity function, measured by the Fugl-Mayo assessment, FMA, which scores voluntary movement and coordination. Second, activities of daily living, assessed with the Barthel Index BI, reflecting a patient's independence. Third, spasticity or muscle stiffness, measured by the modified Ashworth scale MAS. These standardized tools allow for meaningful comparisons across studies and interventions. Review compared 8 different approaches: NMES, FES, TMS, RPMS, and combinations such as NMES plus TMS, NMES plus RPMS, and FES plus TMS, plus conventional rehabilitation as a control. This broad comparison allowed researchers to rank not only single therapies, but also their combinations, providing a clearer picture of what works best for stroke survivors seeking to regain arm function. Among all interventions, the combination of neuromuscular electrical stimulation, NMES, with repetitive peripheral magnetic stimulation, RPMS, showed the greatest improvement in upper extremity function. Patients receiving this combination had a mean FMA score increase of nearly 15 points over conventional rehab, a clinically meaningful difference. This suggests that combining electrical and magnetic stimulation may have a synergistic effect, especially in the early stages after stroke. NMES alone, NMES combined with TMS, TMS alone, and FES also showed significant improvements in upper limb function compared to conventional rehab. NMES alone ranked second, with a mean FMA improvement of about 9 points. NMES plus TMS and TMS alone followed, while FES also provided a modest benefit. These findings highlight that both electrical and magnetic stimulation can play important roles in stroke recovery. When it comes to improving activities of daily living, the combination of NMES and TMS came out on top. This pairing led to the largest gains in Barthel Index scores, indicating greater independence in daily tasks. TMS alone and FES were also beneficial, but NMES plus TMS had the highest probability of being the best intervention for ADL improvement. This suggests that different combinations may be optimal depending on the specific rehabilitation goal. Interestingly, none of the stimulation therapies, including NMES, FES, TMS, or RPMS, showed significant benefits over conventional rehabilitation for reducing spasticity. This means that while these interventions can improve movement and independence, they may not be effective for managing muscle stiffness. For spasticity, other treatments such as medications or injections may still be necessary. Subgroup analyses revealed that NMES plus RPMS was especially effective for patients in the acute or subacute phase after stroke, and for those with more severe initial impairment. In chronic stroke, NMES alone was the top performer. This suggests that timing and severity of stroke should guide therapy choices, with early and intensive intervention offering the greatest potential for recovery. While effective, some stimulation therapies have drawbacks. TMS can cause headaches or, rarely, seizures, and electrical stimulation may lead to skin irritation. RPMS is non-invasive and generally well tolerated, but the equipment can be expensive and less available in smaller clinics. NMES and FES are more affordable and widely used. Cost and side effects should be considered when selecting a therapy for each patient. Despite promising results, the overall quality of evidence was rated low to very low. This was due to inconsistencies, small sample sizes for some interventions, and potential publication bias. More high-quality, large-scale randomized trials are needed to confirm these findings and refine recommendations for clinical practice. For clinicians and patients, these findings suggest that combining NMES with RPMS may offer the best chance for upper limb recovery after stroke, especially early on. Where RPMS is unavailable, NMES alone is a strong, cost-effective alternative. For improving daily living skills, NMES plus TMS is most promising. However, for spasticity, other treatments remain necessary. Individual patient needs, resources, and therapy goals should guide intervention choices. Summary: electrical and magnetic stimulation therapies are valuable tools in stroke rehabilitation, with certain combinations offering superior results for upper limb recovery and daily living independence. However, the evidence is still evolving, and further research is needed to strengthen recommendations. As technology advances and more studies emerge, rehabilitation professionals will be better equipped to tailor interventions and maximize recovery for stroke survivors.